Now we'll be taking a look at the first half of Chapter 14 at nutrition support, and we'll be discussing enteral nutrition. So this is using the GI tract. So looking at planning and implementation of these nutrition interventions. So again, our major concern with malnutrition, with approximately 30 to 50% of hospitalized patients being malnourished, 18% of nursing home patients malnourished, and 42% are at risk for malnutrition. So this results in a reduced quality of life and increased healthcare cost. And so this may be remedied by providing nutrition support. Now, nutrition support actually has multiple categories. So this can be a change in the diet, this can be supplemental foods, and this can also be enteral and parenteral nutrition. So what we're discussing today is we're going to focus on enteral nutrition, with our lectures in Nutrition Disease 2 focusing on parenteral nutrition. So again, why is malnutrition such a concern? And so on, again, we talk about on one hand, you have the hospital, right, which is invested in dietitians, and it's very important, looking at the diagnosis of malnutrition from a billing standpoint. So a new diagnosis of malnutrition causes a ICD-10 code, which then allows for billing. But then we, taking a look at patient care, right, what we're concerned about is that our patients are at increased risk of infections, delayed wound healing, and delayed return to home, work, or ADLs, right, those baseline activities. Now, part of this is remembering, and when we take a look at, is that we spoke on the previous slides about malnutrition, especially in the nursing home. And I think there's this conception that all nursing home patients are there for long-term care, when in fact, quite a few nursing home residents are actually just there for short-term rehabilitation. So these patients are going to be transferred from an acute care facility, then going to go to a acute care. They're from the acute care facility. They're going to the nursing home just to complete physical therapy / rehabilitation, and they will then return home. So again, if those patients are malnourished from their stay at the hospital, or they were malnourished before they went to the hospital and now they're at the nursing home, again, it's our responsibility for treating this malnutrition and other diseases, again, looking at the appropriate nutrition support. So it's not just chronic malnutrition and long-term residents, but this may also be in patients who have recently stayed at the hospital or have short-term injuries or illnesses. Possible diagnoses that may warrant this type of intervention: inadequate energy intake, inadequate oral food and beverage intake, inadequate intake from enteral or parenteral nutrition, inadequate fluid intake, inadequate bioactive substances, increased nutrient needs, or the malnutrition itself. Other possibilities or causes may include inadequate protein energy, swallowing difficulties, altered GI function, impaired utilization, involuntary weight loss, and self-feeding difficulty. Now again, we're discussing primarily enteral nutrition here, but you may see, for example, altered GI function, we would want to transition from enteral nutrition to parenteral nutrition. Or swallowing difficulty may be the start of enteral nutrition. Or impaired utilization, we may need to change formulas. So again, looking at some of our definitions, we have nutrition support. So delivery of formulated enteral or parenteral nutrients for the purposes of maintaining or restoring nutrition status. And the focus of today's lecture is enteral nutrition. So again, looking at these nutrients through the GI tract via a tube or catheter. And parenteral nutrition, again, being done intravenously. Now again, when we're taking a look at our authority, so it's going to be ASPEN, which is the American Society for Parenteral and Enteral Nutrition. They have a lovely 56-page document that details how to conduct and use enteral and parenteral nutrition in acute care patients. They then have sub-guidelines for different conditions, pediatric patients, etc. So let's take a look at which nutrition support regimen is most appropriate and how we make that decision. So when patients are unable to eat enough to support their needs for more than a few days, we're going to consider nutrition support. Now remember, the nutrition support was that umbrella term. So we're taking a look at specifically as enteral versus parenteral nutrition. So enteral nutrition should always be considered first if the gut works. So whenever the gut is still functioning, we should be using it, right? Animals eat through their guts, not through their veins. Now we can, right? We can use that artificial nutrition, but again, when we're looking at optimal blood glucose control, when we're looking at types of absorption, when we're looking at long-term health and maintenance of the GI tract, if the gut works, we should be using it. Now, if the patient does not have sufficient GI function, if they're not tolerating enteral feeds, if there's severe damage, etc., then we're going to use parenteral nutrition. But again, our goal is to actually wean that parenteral nutrition and transition back to the gut as soon as tolerated, right? As soon as we are medically cleared to do so and it's appropriate, we want to try and switch that patient back to enteral nutrition. Again, we're also looking at long-term complications, not just the immediate. So why do we prefer enteral nutrition over parenteral nutrition? So again, this helps preserve the mucosal barrier function and the integrity and overall GI function. It improves and preserves the immunological function. So again, we've discussed this before, but actually looking at that leaky gut syndrome. So again, we want to maintain the health of the individual cells and the integrity of that barrier in the GI tract. Enteral nutrition helps lessen the catabolic response and decreases the incidence of hyperglycemia when compared to parenteral nutrition. So again, if I'm pumping sugar directly into your blood vessels, we can see how this might cause hyperglycemia versus enteral nutrition through the gut. You digest and absorb the nutrients just as you would with food. And on a comparison basis, enteral nutrition is much less expensive. So depending on benefits, insurance, billing, etc. So parenteral or IV nutrition starts at $1,000 per day and gets more expensive from there, whereas parenteral nutrition is pennies on the dollar in comparison, right? Enteral nutrition, so these tube feeding formulas are much more cost effective, with the exception of a few very therapeutic, very complex formulas. So again, we've talked about enteral nutrition, also known as tube feeding. Now that being said, right, the same way that we're changing our language, which is so we don't refer to patients as tube feeders, right? So we'd use the patient's name or the patient who has a PEG tube or a G tube, etc. The same way we would say, right, it's not a diabetic, it's a patient with diabetes. So again, just kind of be aware of the culture and the language. So enteral implies, right, that we're using the GI tract, and so this is for patients who have a functioning GI tract but aren't able to feed themselves. So this may be post-stroke, this could be swallowing dysfunction, this could be altered mental status, this could be because of the stroke, they're not able to use their hands and arms appropriately to feed themselves. And disorders of the upper GI tract can be bypassed by inserting a feeding tube below the dysfunction. So for example, if someone has had damage to their throat or esophagus, this could be a cancer treatment, this could be structural damage, etc. Or if they've had, for example, gastric cancer, etc. We can place the tube below that into the small intestine, and again, still using the GI tract for absorption and digestion, but going below, right, the malfunctioning portion of the GI tract. So here you can see a list of possible conditions that often require nutrition support. And this is not the only list, and this is quite expansive, but again, there's a variety and many, many reasons that patients may be on enteral nutrition. So here we have a heuristic. Unfortunately, the last page I'm not able to recover at the very bottom, but in essence, we're taking a look at how do we determine what type or is a tube appropriate. And so you can see, so are they meeting their needs? Yes, then we don't do anything. If not, right, we can take a look at supplements versus taking a look at, so if there's a non-functional GI tract, we would use IV nutrition, and then again, we'll go more into that next class about which type of IV nutrition versus if we tried fortified foods and they don't work, we can use an enteral tube. Again, how do we place it? And then you can see, do we use the nose, the stomach, so on and so forth. Now, so far, it sounds like sunshine and rainbows and that we should always be using enteral nutrition, but it's not perfect. And so looking at enteral nutrition, so there's the potential difficulty of administration, which is the regimen itself. Some of them are very simple, some of them can be more complex. It may have poor tolerance. So because this is a liquid with all of your nutrients in it, this may cause osmotic diarrhea, and so it may pull a lot of water into the bowels. Now, again, there are specialty formulas. Now, those are more expensive, but they can improve tolerance. The patient may have difficulty meeting their needs, and so for most average-sized people, it's not too difficult to find a formula. But as people become very small, so if you have somebody who is 5 foot or under, if you have somebody who is 100 pounds or smaller, or you have people that are very large, so you have somebody over anything about 250, somebody who's 6'4" and above, the problem becomes is that something usually goes wrong with the formula, which is it doesn't have adequate vitamins and minerals. It either has too many or not enough calories, or too much or not enough water, based on an individual's needs because of their body proportions. A surgical procedure is needed to place certain types of tubes. So depending on if you're trying to bypass a damaged structure, if you're looking at something after a cancer resection, etc., then again, it may be difficult, or you need a surgery at the same time to place the tube. And there may be increased susceptibility to infection. Now, this is both with parenteral and enteral, but it's increased susceptibility compared to oral. So again, if I'm poking a hole in your body, as clean as I try to keep it, right, just like an ear piercing, it can get infected. So again, the questions that we want to take a look at with enteral nutrition. So when you're writing this prescription for this patient, which is the type of gastrointestinal access, so how the GI tract is being accessed. Is this through the stomach directly? Is this down the esophagus through a tube? Is this in the nose? Is this through the mouth? Is this going directly into the small intestine? Which formula will you choose? And we'll discuss how to make that decision based on the patient's needs. And then within the specific formula, it's actually specific feeding techniques. So again, what's the best schedule or regimen? Are they going to be on continuous? Are they going to consume these supplements like they would orally, so with multiple meals per day? And lastly is equipment. And so again, do they have access to a pump? Are they going to use syringes, etc.? Who's going to, right, how are we going to keep the tubes clean? Do they need to do tube exchanges? So on and so forth. And so that's actually what's called durable medical equipment. And so there are companies that actually lease this equipment, and they actually do have dietitians on staff to answer any patient questions about the management of this equipment, exchanging it, etc. So here you can see the tube. And so the nutrition actually goes through, if you look at the rubber stopper, so the black end, whereas what you'll see with the white end is a bolster. So you can see that the actual outlet itself is very small, but then there's a large bolster, and that is so the tube does not accidentally get pulled out. So once it's inserted, if it's done surgically, they'll place a large bolster on the other backside, kind of like a button to help prevent you from pulling it out accidentally. Or this may be an inflated balloon that again can be inflated once it's inserted to again make sure that it's not accidentally pulled out. So the first question we asked was GI access. So things to consider when we're taking a look at how this is going to be done, which is how long the patient will be receiving enteral feeds. Is this going to be a short-term or long-term intervention? What's the risk for aspiration or tube displacement, which is patients may pull on these purposefully or accidentally. So if they've had altered mental status, they're sleeping, if they're younger, right, they may pull on them without thinking about it. The patient's clinical status and overall medical condition. The presence or absence of normal digestion and absorption. So again, do we have our normal anatomy? So what if this patient has had gastric bypass? What if this patient has had some kind of removal of their structure due to cancer? So on and so forth. What if a change in the pancreas and this changes digestion? And then again, whether a surgical intervention is planned, as some types of tubes require a surgery to place them, whereas some can be placed at the bedside. So again, if a future surgical intervention is planned, that might be an optimal time for tube placement, or it might not. So the access and route are described by where it enters the body and where the tip of the tube is located. Now, again, we talked about that some of these may be temporary, but when we take a look at the world of enteral nutrition, temporary is somewhere between 3 to 4 weeks at max. So you're looking at somebody could be on this for an entire month, and they would call that temporary. So our temporary measurements for feeding include the nasogastric tube, also referred to in charts as an NG tube or an NGT. So this starts in the nose, so it's inserted through the nose, and the tube ends in the stomach. We have the orogastric, OG, or OG tube, and this starts in the mouth and goes to the stomach. So that, yes, kind of like a frog with a fly or some kind of critter, there's always a tube in the corner of your mouth. We have the nasointestinal tubes, which start in the nose and they end in the intestine. So these can be ND or ND tubes, NJ or NJ tubes. And so the ND tube is in the duodenum and the NJ tube is in the jejunum. Now these are also referred to as post-pyloric feedings. So again, we're going below the pyloric sphincter or through the stomach. And so this is done for a variety of reasons. So this could include gastroparesis with persistent vomiting, gastric outlet obstruction, gastric surgery, so again, a severe ulcer, etc., where again, we're still using the GI tract for digestion and absorption of nutrients, but due to some change in function or structure, we've needed to bypass the stomach. So here we can see the nasoenteric routes. And so you can see again in blue the different locations of the tube. So in this case, it's going through the nose to the stomach, could go to the duodenum or the jejunum. Now it also talks about jejunostomy and gastrostomy, which again are long-term tubes. Now the problem with nasogastric tubes is they're uncomfortable and they can cause nasal and upper GI irritation. So again, similar to being dunked in the pool, right? You kind of have that feeling of being congested at all times, and patients may state this is very uncomfortable or they want it removed. The other problem is these can be easily dislodged or pulled out. And so quite literally all you do is kind of gently pull on them and cough, and you can remove the tube. Now to help prevent this, especially in facilities that have a lot of altered mental status patients, so a lot of long-term recovery, is these may be what's known as bridled in. And that is, so what they'll do is they'll put 2 or 3 stitches in the patient's nostril to make sure that the tube is not easily pulled, right? So as you pull on it, it hurts your nose and you stop pulling, giving the nurses time to come reorient the patient, calm the patient down, but so they don't actually pull the tube out. So these may have to be replaced frequently, though, if they are being dislodged. Now, there has been a recent change with the guidelines. So according to the national guidelines, it is allowable for dietitians to place NG tubes. Now, what you're now seeing is that individual states will regulate this and take a look at your scope of practice. So it is now allowed in Florida that dietitians can place NG tubes, but this is usually seen as above and beyond normal duties. This is not required as a minimum duty at this time, but you will see some ICU dietitians or more acute care dietitians that are trained in the placement of NG tubes. Now again, we said that temporary was 3 to 4 weeks or about a month. We also have more long-term solutions, and so these are our ostomies that are inserted through the skin. So a gastrostomy tube goes through the skin into the stomach. A jejunostomy goes through the skin and into the jejunum. And a surgical gastrostomy, again, it still goes through the skin and into the stomach, but this is placed by a surgeon, and this is typically done at the same time as another surgery. So for example, if the patient was placed under anesthesia because they had some kind of damage to their throat, for example, a Mallory Weiss tear, etc., so they had to have a surgery, we could then also, the surgeon would place this tube at the same time to be used when the patient wakes up to provide nutrients and medications. What you'll see most frequently, though, and what's very simple now, is what's known as a PEG tube. So this is a percutaneous, or through the skin, endoscopic, so using an endoscope, gastrostomy, so again, a tube that's going to go through the skin and into the stomach. So this is a through the skin and into the stomach tube using an endoscope and local anesthesia. So this is not considered a surgery. This is a non-surgical technique. So this is performed by a gastroenterologist. But what's nice is that this is done as either an outpatient procedure or can be done at the bedside. So this doesn't require general anesthesia, so it's appropriate for elderly patients. It's much faster, but again, you're still getting the same access. And so again, they also have the option of what's known as a button or low profile. So instead of about 8 inches of tube, it may be much lower profile, so especially in the pediatric population, so the tube is not accidentally dislodged. So here again, you can see the peg tube. So you can see in the upper left corner, so you can see the bolster to make sure that it doesn't accidentally become dislodged. And then you can see the very low profile access. So again, this is good for body image issues, but then also in the pediatric population to make sure that it's not accidentally pulled, gets into a soiled diaper, etc., etc. Here you can see a more traditional one. So you can see we're looking at several inches of tube. So again, if the patient is, as long as the patient's aware enough to not mess with it, again, it's perfectly safe in both the pediatric and adult population, but the low profile does provide alternative options. This is what a traditional tube would look like, where you're looking at several inches of tubing. Now here you can see again the difference in the placement sites. So on the left, we have the naso placements. So we have nasogastric, nasoduodenal, and nasojejunal. And on the right, we have gastrostomy and jejunostomy. So here you can see the actual system. Now this is one specific brand, so this is the CoreTrack system. So looking at, you can see then how the tube is going to be placed. And so you can actually see the graphic on the screen, right? As you can see, it's advanced through the stomach, through the pyloric sphincter. Right, so you can actually then see clearly the curve of the stomach, and then looking at what you're going to be looking at with training is how far you advanced or where you're at in the stomach versus in the small intestine. So again, we've talked about where these can start and end. So they can start in the nose or they can go through the skin. But how do we determine if we're going to use the stomach or the small intestine? So the tubes are easier to place into the stomach, but patients that are receiving gastric feeds or into the stomach are at higher risk of aspiration pneumonia, and critically ill patients may not tolerate feeds in the stomach. So they may experience abdominal distension or discomfort. We may have vomiting or persistent gastric residuals, which is the amount of food or fluids left in the stomach is greater than 400 milliliters. Now to put that in perspective, 237, or in essence what we call 240, is 8 ounces. So 400 is just shy of 16 ounces. So you're looking at approximately 14 ounces. So when you think about a standard water bottle is 16, this is, a little before the top. So again, these residuals can be food, liquid, material from a previous feed, can be medication flushes, etc. So high gastric residual volumes may increase the risk for aspiration, which is again, it builds up in the stomach and in essence, similar to being vomit, it can end up being regurgitated into the lungs. So when we first start feeding patients, gastric residuals are checked every 4 to 6 hours. However, now this is done on a hospital by hospital basis. They will determine what is a quote unquote high gastric residual. The Aspen guidelines state that as long as the gastric residual is less than 500 milliliters, we do not stop feeding the patient. So the Aspen guidelines should state that we want to see 2 residuals, both greater than 500 milliliters, before we stop the feeds. So anything less than 500, do not stop the feeds. Now what you will see, for example, is some facilities may say 1.5 times delivery rate. So if I'm giving the patient 50 milliliters an hour, 1.5 or 1.5 times 50 is 75 milliliters per hour. So if you see a buildup of 75 milliliters per hour, that institution may suggest that you stop the feed. Aspen guidelines do not recommend that, but again, facilities will set their own standards and recommendations. So feedings will often be stopped unnecessarily, not advanced to goal, and what we'll have is then the patient will not receive adequate nutrition and will be underfed. So again, you're looking at that's for the previous example with 75 milliliters, that is significantly lower than 500 milliliters. So again, if the nurse then stops the feeds for the rest of the day or refuses to advance the feeds towards goal rate, then the patient will not receive enough nutrition during the course of the entire day. So the practice of checking gastric residuals, again, is believed that high gastric residuals are a marker for increased risk for regurgitation or aspiration. And so again, I'm sorry, I apologize, this is a typo. We have correlation, but we have not established causation for aspiration pneumonia and ICU and hospital mortality. So that is, we don't have a causation. We do see a correlation, but we do not see a causation. I apologize for that typo. Now the second question is what formula do we use? So each hospital will have established what's known as a formulary, which is in essence the guide for the brand and types of formulas that they stock. And so in essence, it's pretty standard that every hospital will carry regular, a diabetes formula, a dialysis formula, some kind of critical care or high protein formula, and then they may have some other types of formulas for tolerance, low osmolality, etc. Now there's many different brands, many different types of formulas, many different subcategories. So again, depending on the size of the facility will determine the expanse of the formulary. A small community-based hospital will have a very limited formulary versus a very large regional facility is going to have an expansive formulary with many different types for different types of patients. Now these formulas vary based on the substrates they're made out of, their density of nutrients, their osmolality, and viscosity. So they may have more or less protein, more or less broken down, more complex or less complex carbs, different types of liquid lipids or total amount, differing amounts of vitamins or minerals, differing amounts of water, and electrolytes. For example, that renal formula will be low sodium, low potassium, low phosphorus. And so here we can see, for example, one way to determine the different types of formulas you would need to use. So again, looking at different types of energy needs, looking at if somebody is having tolerance to carbohydrates, so they may need a limited carbohydrate formula, looking at if they needed sodium restricted or other types of electrolytes or increased protein. So factors to consider when choosing a formula. So we're going to take a look at the total calorie and protein density, the GI function, the presence of lactose, the electrolyte makeup, again looking at those specific macronutrients, so what state they're in, how complex or how broken down, and the total amount of that protein, fat, carbohydrate. For example, our dialysis formula is going to be higher in protein, whereas our pulmonary formulas are going to be higher in fat and lower in carbohydrate. Now also a little bit beyond our scope for an entry-level dietitian is viscosity, but it should fit, right? Most of these formulas now are formulated to fit in your standard tube sizes. So unless somebody has a modified tube for a very specific reason, right, these formulas should work in all standard tubes. So the first macronutrient we'll take a look at is protein, which in most formulas is somewhere between 6 to 25% of the total calories. Now you can look at the makeup, which they can be casein, whey, or soy-based. And your standard formula, like Gevity, is going to contain an intact protein, which means the patient needs functioning enzymes to break this protein apart into peptides for then absorption across the GI tract. We also have elemental or pre-digested formulas, which contain dipeptides, tripeptides, and amino acids. You may also see on the label hydrolyzed or chemically defined formulas, and these are used for patients with enzyme deficiencies, malabsorption, protein allergies, or other conditions that result in maldigestion. So these modified dipeptide, tripeptide, and amino acid formulas require less digestion, but they have an increased osmolality, so these may affect GI tract, and they come at a much higher financial cost. The second macronutrient to consider is carbohydrates. Now again, depending on the patient's medical condition, these formulas can vary greatly, which is anywhere from 30 to 85% of their total calories. Now, a standard formula is going to use corn syrup solids, monosaccharides, oligosaccharides, and dextrins. You may have hydrolyzed formulas, which are going to be broken down using maltodextrins or cornstarch. And if the formula is intended to also be used as an oral supplement, there may be some sucrose. So for example, the major difference in Jevity and Ensure, in addition to the vitamin and mineral composition, is the fact that the Ensure is sweetened with sucrose, so it has some sweetness to it, whereas your Jevity has no sugar. It does contain a significant amount of carbohydrates, but it is low in sugar. Most commercial standard formulas are going to be lactose-free or low enough in lactose that they could label themselves as lactose-free. And you've also seen the addition of fructo-oligosaccharides, which are going to be intended for GI health. And so again, these are fermented to form short-chain fatty acids. And again, this is in essence fuel or as a prebiotic for the bacteria, right? So again, you have that relationship where again, you want to encourage a healthy GI tract. So with the appropriate amount of bacteria that then produces short-chain fatty acids to be used in the large intestine. Now you can also find formulas that are fiber-free, low residue, or formulas with additional fiber. Again, here you're looking at bowel function, and then you're also looking at a possible thickener with higher viscosity. Again, to consider the fact that it's going to be more difficult to go through certain tubes, but again, we now, with modern tubes and modern technology, this isn't as big of a deal. So there are some very high density formulas. They're going to be thicker with that higher viscosity. So the most famous one is 2-cal, which is extremely dense in calories and is known for clogging tubes. But even then, it has had a significant improvement in recent years. And then looking at lipids, which can be anywhere from 1.5 to 55% of total calories, with somewhere between 15 to 30% of total calories in most standard formulas. Now, standard formulas are going to use corn, soy, safflower, sunflower, or canola oils. Again, this is typically due to cost concerns. And then elemental or hydrolyzed formulas will use 2 to 4% long-chain fatty acids, again, to ensure that we're getting our essential fatty acids, our linoleic and linolenic. And then will also contain medium-chain fats or medium-chain triglycerides as the remaining fats. So because these do not absorb with bile salts or pancreatic lipase, they can be absorbed directly into portal circulation, but the MCTs do not provide our essential fatty acids. So omega-3s and omega-6s are included, but again, it depends on in what concentration. So we talked about in the pulmonary chapter, the formula Oxepa has a significant fishy smell and is very high in omega-3s, whereas other formulas will contain much smaller quantities of omega-3s. You also may see the addition of structured lipids. So again, looking at they may contain specific fatty acid chain lengths or different types of fatty acids for specific disease processes. So the vitamins and minerals, most of these meet the DRIs for healthy adults within a specific volume. So I will show you this is on the actual specific label, and it will tell you how much volume or how much formula you need to give someone to meet 100% of the DRIs. If the patient is unable to meet the DRIs, they may need an additional multivitamin to make sure that they do not become deficient in any of the micronutrients. Now, these will be adjusted based on specific disease processes. So again, if somebody has wound healing, immune function issues, or stress, right, so metabolic stress, then they're going to maybe need supplements. But if they have renal disease or liver failure, then again, that micronutrient content will vary. So what you'll see, for example, is the renal one will be low in sodium and potassium and phosphorus. And the liver one, again, we'll take a look at, again, maybe higher or lower. Pulmonary, again, higher or lower, again. So looking at, again, if we're worried about fluid retention, if we're looking at that congestion, etc. Electrolytes, though, are going to be in modest amounts compared to the oral diet. So again, because we're not as concerned about the patient sweating, right? They're just going to be in a controlled temperature hospital room. We're not as concerned with sodium and potassium in our standard formulas. So if the patient is having GI tolerance issues, diarrhea, a drainage due to a fistula, etc., then they're likely going to need additional electrolytes. Now we talked previously about that thicken or increased viscosity with certain formulas. So again, what we have is what's known as our fluid and nutrient density. And so formulas are given a number and as the number of calories contained within 1 milliliter. So a 1.0 formula is 1 calorie in 1 milliliter. 1,000 calories in 1,000 milliliters, or 1 liter. Your thickest formulas are going to be 2.0, which is 2 calories in 1 milliliter. So a 1 liter solution would have 2,000 calories. Now remember, our recommendation for adults is 1 milliliter per calorie, or 30 to 35 milliliters per kilogram. So for our patients receiving a 1.0 formula, we're actually going to meet our fluid needs, usually with the tube feeding. But if you increase the density, 1.2, 1.5, 1.8, or 2.0, then the patient is likely not going to get enough fluid from the formula itself. Now to give you an example though, and so how to approximate this, so your standard 1 calorie per milliliter formula is approximately 85% free water. 1.2 is approximately 80%, 1.5, 76%, and 2 cal, approximately 70%. Now the reason why this matters is because tube feeding is not a solution, it is a suspension. Now this goes back to the food science class and the difference in a true solution versus a suspension. So for example, in a true solution, I have dissolved the sugar into the water. But in a suspension, this is kind of like milk, which stays permanently suspended. Or if I have something like sandy water, if I let it settle, what you will see is that it's not all water. And so what we have in this diagram in essence is I could probably flip the photo upside down, but when you have the sandy water or the salad dressing, etc., if I let it sit still long enough, you'll see that the bottom portion is going to be the chunks of solids, the sand, the spices, etc. Or in the case of the tube feeding, the protein, the fats, etc. And then I also have the water. So for example, 1 liter of formula does not provide 1 liter of water. So if we take a look at the previous slides, you will see it's based on a percentage. So again, 1 liter of formula does not provide 1 liter of water. It's based on that percentage, or you can look at each individual formula. So as we increase the density of the formula, we need to consider we will also be increasing the osmolality. Now again, most bodily fluids, so blood, saliva, tears, etc., is approximately 300. Your isotonic formulas will have that same osmolality, and this minimizes the risk of diarrhea, dumping syndrome, etc. Most commercial feeds are going to be somewhere between 300 to 600. So with the exception of the formulas that are designed to be isotonic, they're going to be somewhere between 300 to 600, or about almost twice as concentrated as bodily fluids. Now this is pretty similar to oral beverages. So for example, looking at your standard milkshakes, your sodas, etc. So again, unless there's some digestive or absorption issues, these are generally well tolerated. But if there's a specific disease process, if there has been, for example, gastric bypass surgery, etc., then we may need to take into account that there's an increased risk of diarrhea with these formulas. So again, we said that very rarely will the tube feeding meet 100% of the patient's fluid needs. And so what we'll give is what's known as a water flush, or additional flushes of water through the tube. So this does two things, right? This keeps the tube clean, as well as providing the patient the additional needed water for the day. Now we have to determine is their total flushes and their total fluid needs. So To figure all this out, the first thing we do is determine the total amount of fluid or water the patient needs for the day. We need to determine how much fluid they're getting from their formula, medications, or any other sources, and subtract those two numbers. So for example, if I need 1,000 milliliters per day, and my formula only provides 750, I will be short 250 each day. So this will be corrected by giving the patient additional free water flushes. Now, looking at these formulas and looking at this regulation, so there is some regulation on these, and these are considered medical foods. Now, the reason why this is important is this has to do with how they're produced, which is these formulas are all produced under very specific cleanliness conditions, so there's standards they have to meet. However, there's no requirement that they be guaranteed efficacy or benefit. So, for example, in the case of Pulmicare, or in the case of Oxepa, the formula does match the established research, which takes a look at anti-inflammatories and lung inflammation, looking at decreasing carbohydrates in lung diseases, etc. But a lot of times you'll see is that they'll create a new product year in and year out. They keep changing their formulas, and there's always some new research or some touted benefit. But what you want to take a look at is where did that research come from? And so Abbott does put out some good quality research, but just again realize, was the researcher paid to produce this research? How significant of a difference did it actually cause? Etc. So just be critical and realize that, of course, when you're talking to the formula rep, they're going to be telling you that the formula was the greatest and bestest, newest thing they've ever created. Cost is also a consideration, so this is going to vary based on the total amount of formula purchased. So for example, if you're ordering 100 cases a week, you may get a certain price discount. If you order 200 cases a week, you may get another price discount, etc. Companies may also give a bonus discount if you are exclusively using their products. So for example, if I only carry Abbott products in my hospital, they may give me a 5% price break, versus if I use a mixture of different brands, they may not. And then of course, the more therapeutic or the more elemental or specialized the formula is, the more expensive it's going to be. And then lastly is looking at feeding techniques. So the goal and what we want most patients to transition to is a bolus feed. And so this is for a patient who's clinically stable with a functional stomach, in which case, so a rapid administration of 250 to 500 milliliters of formula several times a day. This is given via a large syringe, and again, it's going to be measured and then administered through the feeding tube. And so this does not require a pump and can be fed using gravity. So in essence, you're looking at somewhere between drinking 18 to 16 ounces several times a day, which you can imagine, if you were on the smoothie diet, could you drink a 16-ounce smoothie 3 or 4 times a day? And the answer is probably yes. So here you can see this large syringe, and again, the formula will be poured into the syringe, held right above the stomach, and then allowed to drain into the stomach for digestion. And so here you can see with formula, so again, depending on the reason for the condition, again, these are very portable. This formula, right, as long as you have clean water to flush it, this doesn't require any special equipment. This requires no electricity. Again, if you're worried about hurricanes, power loss, etc., right, as long as you have access to the cans of formula and clean water, you're pretty much good to go. So here you can see other examples, right, of the bolus tube and again the large bore syringe. Our other option is intermittent feeds. So this is here when we have quality of life issues, and so the patient needs to be more mobile or have free time not connected to the tube, in which case it's kind of this hybrid, which is the bolus regimen is very much I feed myself breakfast, lunch, dinner, and a snack. I just pour it in, flush it down, disconnect, plug up the tube, and go about my business. Here we're looking at, so this is 4 to 6 times per day, but for much longer periods of time. So this is a 20 to 60 minute period. So again, this is still, 6 times a day for an hour. So this is still eating up 6 hours a day. Whereas you could do a bolus regimen, in essence, in 4, 10, 15-minute meals. Whereas this requires a significant more portion of time. Now this can be done via a pump, but very quickly, or gravity. And again, we're looking at 100 to 150 mils per feed. So these are smaller in volume and done over a longer period of time to promote tolerance. And hopefully the patient will transition to bolus feeds. And so here again, you can see, so again, these would be placed in a bag. And again, the timing would vary based on how long the regimen was set for, be this a 1-hour feed, a 45-minute feed, etc. Most patients start with, so again, our goal is bolus feeds. That's what we want for every patient. But most patients will start with a continuous feed. So this is for patients who do not tolerate large volume infusions. They have a compromised GI function because of a disease or some other process, surgery, cancer therapy, or other physiological impediment. You also may see this known as a continuous drip. And so this does require a pump. And now the one clarification is that if a patient is on a jejunostomy feed, then they will require it to be continuous. So we don't do bolus feeds into the jejunum or into the duodenum. And again, that makes sense because again, you would normally have the stomach and the pyloric sphincter to slowly infuse nutrients into the small intestine, right? We don't, in essence, chug into the small intestine. We don't do that with a feeding tube either. Now, that being said, in the hospital, these are very convenient as these are much easier to administer and they're less time consuming on the staff. But there is no mobility restriction, which is if you want to go anywhere, the patient has to carry around the pump, the bag, the tubing, etc. And this has a lot of disposable supplies, which is a daily bag, tubing, etc. So you have a lot of increased plastic waste as well. Now, what patients may receive is known as a cyclic feed. So, for example, if we're trying to get a patient to begin eating during the day and they're working with speech therapy, they may be eating their tube feeding at night while they eat food during the day. And you do have the rate, which is milliliters per hour, or total volume, is going to be programmed into the pump's settings. And we'll discuss when we take a look at the worksheet. So rate is determined by, in essence, the total amount of formula the patient needs divided by the number of hours they're going to be connected to the pump. Most of the time with continuous, this is going to be 24 hours. Now, that being said, we have to establish tolerance. And so what we do is we don't just start immediately cranking the nutrition at full speed and hope for the best. We will start this at a quarter to half rate of the goal rate and advance it every 8 to 12 hours. So if I want you to get 40 milliliters an hour, I'll start at 10. 8 hours later, I'll do 20 milliliters an hour. 8 hours later, 30 milliliters an hour. And 8 hours after that, 40. And so it takes me approximately a day of starting this, checking your gut, making sure everything works, and then we'll reach full volume and full rate. Now, we do have what's known as a closed system versus an open system. And so this has to do with how the actual pump system and the fluid and the formula is accessed. So in a closed system, the container is pre-filled, and then the liquid is going to be sterilized at the manufacturer, and in essence is sealed until it is spiked or plugged into the tube. So this actually decreases our risk for germs, contamination, etc. An open system, in which case you saw in the previous photos, is a large, in essence, a large Ziploc bag. The nurse will open individual cans and pour them into the bag before then, in essence, zip-locking the bag or plugging the bag and then hanging it. Now, because of this risk of contamination, an open system only hangs for 4 hours at a time. So you can imagine, right? So That's multiple times per day. The tubing in the bag needs to be changed out for each cans to make sure that there's no contamination of germs. Whereas the closed system can be hung for an entire 24 hours without having to be changed, as there's less risk that outside germs have been introduced. And so here we have these bottles, right? So you can see on the upper right, you can see that the bottle is plugged in directly into the tubing. This is a closed system, whereas instead this would be a bag if it were an open system. So the equipment needed, so we talked about is the tube itself. And so again, these are now, they're quite soft. They're much softer than they used to be, and they're much more flexible. So they used to be very, very stiff tubes that were very uncomfortable. Now they're a lot softer and more flexible, but they do have weighted tips, as the concern is that they were used to be so stiff they could actually curlicue in your stomach and then be pumping upwards like a fountain, which was not good. But they are in French sizing, so you'll see what's known as a French gauge. So one French is 0.33 millimeters, and so most feeding tubes are 10 to 14 French. So again, you can imagine then you can do the math that 10 times 0.33 would be 3.3 milliliters, which is a third of a centimeter. Centimeter to 2.54 centimeters to the inch. So I mean, you're looking at extremely small. I mean, you saw how small the tubes were. Again, it would have to fit up your nose, right? These are not large tubes. The formula you saw came in those large pre-filled containers or in individual cans or Tetra Paks. These do require a pump, and they do have a battery backup that lasts approximately 8 hours. But for example, right, if we need emergency power, this is something, right, that will run out of power, but whereas a bolus regimen, right, does not require electricity. And then of course you need all the bags, the syringes, right, and the supplies ought to be labeled, timed, and dated to ensure that they're in compliance for hang time. So here you can see the French size and the equivalent. So we said that 10 French is going to be 0.13 inches in diameter. Now, for maintenance of the tube site, so again, there's a lot of bad publicity that tube feeds are some kind of significant intervention, that this is life altering. And yes, it does change your daily life patterns of how you get your nutrition. But from a physiological standpoint, it's really no different than an earring, right? So you have a hole that goes through your skin into your stomach, and just like an ear piercing, right? If you remove the tube, the hole would grow shut quite quickly. And so just like an ear piercing, we need to wash the skin around the tube with soap and warm water, so keeping it nice and clean. Again, cleaning around the G-tube, again, so if this is at your stomach, looking to make sure there's any drainage leaking out of the skin or any crusting. It should be clean and dry, and again, like any piercing, if it starts to get red, hot to the touch, or irritated, again, you would want to let your doctor know. So again, making sure that the site does not get infected. All right, so here you can see, and I want you to refer back, so this is slide 54. So please take note, you will be using slide 54. Please take note to be using slide 54 for how to determine how to actually write an enteral nutrition prescription. So step 1 is to determine the dosing weight, which is we have to agree on what the patient weighs to make our recommendations. Using the weight from step 1, you will then determine calorie, protein, and fluid goals. So these are going to be based on, for example, the Mifflin, the calories per kilogram, etc. So you'll use all of your standard numbers. So this is a patient who has some other condition or not. Again, you're going to use your activity and injury factors to determine number 2. You'll then choose a formula. So if they have diabetes, you'll choose the diabetes formula. If they have renal disease, you'll use the renal formula. Using the total energy needs from step 2 and 3, you will divide by the density. Remember, the density was 1.0, 1.2, 1.8, 2.0, etc. But you will divide the number of calories per day by the density of the formula. This will give you a volume. Step 6 is you will divide that volume by the number of hours in which you intend to feed the patient. So if it's 24 hours a day, you want the pump running, you will divide it by 24. For example, though, certain medications we said needed to be on an empty stomach, in which case it will be no nutrition for 1 hour before the medication and no food for 1 hour after the medication, in which case you would only be dividing by 22. Number 7 and number 8 are check the electrolyte and check the vitamins and minerals to make sure that they are at the correct amounts. Number 9 is assuming that you have picked the correct amount at the correct rate, establish how this will be delivered, and then 10 is to put it all together and write your final prescription. So an example of a final prescription, you have the specific formula, Gevity 1.2. It will be running for 50 milliliters an hour continuously with 120 milliliter flush every 6 hours via the PEG tube. Glucerna 1.5 at 75 milliliters per hour from 8 p.m. to 8 a.m. via the G tube. Now in reality, right, it would be from 2000 hours to 0800 hours. But again, just to make sure it was on the same page, this is a 12-hour regimen. Osmolite 1.0, 20 milliliters per hour via an NG tube, increase by 10 milliliters every 8 hours until a goal of 60 milliliters per hour is reached, providing 180 milliliters of fluid 3 times per day. Now, complications to be aware of and monitor. So we have tube-related complications, which is the tube can become clogged, twisted, or misplaced. So to prevent clogged feeding tubes, again, we want to flush with at least 25 milliliters of water several times per day. So again, we said the flush served 2 purposes. But we can also use bicarbonate and pancreatic enzymes to dissolve any clogs. So this is kind of like drain cleaner only for the tube. So again, because this tube is going to a human body, it's going to be basically baking soda and pancreatic enzymes. You will see the old wives' tale or the old trick is to use Diet Coke. That is not an approved practice. Whatever your patient does at home is their business. I'm not saying it doesn't work. I'm saying that is not the approved practice. GI complications can include diarrhea. This could be due to high osmolality, but in reality, our patients in the hospital could have C. diff. This could be antibiotic-associated diarrhea. This could be a side effect of a medication or the disease process itself. So again, we could add additional fiber, we could change formulas, but again, we want to make sure that we are checking for those other factors first and not just assuming it's the tube feed. Other risks include aspiration. So to make sure that the patient does not regurgitate and get this formula into their lungs, we want to keep the head of bed elevated to more than 30 degrees, which in essence is sitting up under with a pillow under our back, for at least 1 hour after a feed, or if this is continuous at all times. Monitoring gastric residuals. The patient could become dehydrated, so again, making sure that we're providing enough fluid via flushes, or if the tube is being disconnected for bathing, physical therapy, etc., we may need to increase our rate to make an adjustment for those interruptions. The patient may have high blood sugar or hyperglycemia. Again, they may need exogenous insulin, so again, this would be from the physician, but you would consult with them. But this could be due to steroids, antibiotics, metabolic stress, etc., that increase, right, their overall insulin needs. Again, it's not from the food itself, but because they're having insulin resistance due to a disease process. We're also concerned about under and overfeeding. And so again, underfeeding may delay nutritional repletion and wound healing. On the flip side, we discussed that in the pulmonary patient, we may underfeed on purpose. So it's known as permissive underfeeding, where again, we want to avoid metabolic and respiratory complications. So this is things like high blood sugar, high CO2, etc. Other long-term consequences of overfeeding include high triglycerides and fatty liver. So again, we need to take into account if we're overfeeding, our patients may actually gain weight and have a negative impact on their health. But if we underfeed, it could have a negative impact unless we're aware that we're doing it on purpose because we're trying to protect them from something that is worse. So how can we help prevent gastric residuals and improve enteral nutrition tolerance. So the first step we said was elevating the head of bed to 30 to 45 degrees. So again, this is like having a pillow or two placed under your back. Providing a continuous infusion. So again, making sure that we're not feeding them large volumes at once, giving the time for the stomach to digest, and then through the pyloric sphincter, release the contents into the duodenum. Consider moving the tube further down into the duodenum or jejunum if it's building up in the stomach too much. Checking to make sure that we've chosen the correct formula, that it's not too complex, that it's not taking too much energy or enzymes to digest. Checking our rate. So again, are we giving the patient too much too quickly? Do we need to slow down and provide the formula at a slower rate over a longer period of time? Prokinetic agents. So these are usually a short-term solution, something like azithromycin or Reglan. But again, because of the side effects of those medications and their interactions, those can be used short-term or if there's an underlying disease process, but it's not a medication that we should be using long-term. Now, something that can occur with enteral nutrition is refeeding syndrome, and we'll talk about why this is more likely to happen with parenteral, but can still occur with enteral nutrition. So here we have metabolic alterations with aggressive nutrition repletion of a starved, malnourished patient. And so here we see potentially fatal shifts in fluid and electrolytes that happens in malnourished patients who are receiving this nutrition support, so this aggressive feeding. So when you think about it, when you're typically sick and you have poor intake and you start to feel better, you slowly start eating more food, right? The first day you may have a couple of crackers, some ginger ale. The next day, maybe a piece of toast. Then we start eating some chicken noodle soup, but you very rarely go from 0 to 100 and eat large volumes of nutrients. So when we have a large intake of energy, specifically from carbohydrates, right, in patients who are anabolic, which is patients who are recovering, right, we have a transition or a shift from using ketones from energy to, again, switching back to using glucose as our primary energy source. Glucose metabolism requires a large amount of phosphorus in the form of ATP and a large amount of magnesium, potassium, and thiamine to, again, looking at the cellular level. So what happens is we have an uptake of these nutrients or increased absorption at the cellular level. And so what happens is that this is absorbed from your blood, and so we have a rapid fall in phosphate, magnesium, and potassium, along with an increasing extracellular fluid volume, which leads to cardiac complications. So your blood levels of phosphorus, magnesium, and potassium will decrease because your cells are absorbing them out of the blood. So if our nutrition therapy is too aggressive, our patients may have low blood phosphorus, which impairs cardiac function, respiratory function, and leads to death. They may have that hypokalemia or low potassium in the blood, leading to cardiac arrhythmias. Hypomagnesemia or low magnesium of the blood, again leading to tremors, cardiac arrhythmias, and paralysis. And high blood glucose. And you'll notice that all three of those had cardiac complications, and so refeeding syndrome can be fatal due to this increase in cardiac workload and dysfunction. So who's at most risk for refeeding syndrome? Those who've not been eating or had poor appetite for several days, so the longer you go, the worse the risk gets. Long-term inadequate oral intake, those who present as already malnourished. So again, you'll see that our strategy is that we started nutrition support slowly at a quarter rate. So we want to avoid overfeeding and prevent refeeding syndrome, and monitoring closely in these patients who we know have a history of poor intake, looking at their MAG, phos, potassium, and blood glucose levels. Now you'll see that the Aspen guidelines also have recommendations for these patients, so you'll keep calories at less than 1,000 or right at 1,000 calories per day until these electrolytes stabilize. Now you can't actually order these, but if you communicate with the doctor and let them know the patient is at risk, they will check these electrolytes every day, and then if they are low, they will then provide the patient additional amounts, right? They'll have them placed into their fluids, they'll have additional electrolytes supplemented. Now, also, in addition to supplementation of electrolytes, things to consider is that with enteral nutrition, we can also give supplemental amounts of protein. We can use the tube for medications as well as nutrition, but you do have to make sure that the medication does not clog the tube. And realizing we talked about that planning for that time, which is that the tube may be disconnected for bathing time, for visitors, to participate in physical therapy, to go down for a test or imaging, etc. And just briefly, we've talked a little bit about ethical issues, but again, what we need to focus on is that, again, looking at what does the patient have? So do they have a living will? Do they have, right, have their medical wishes been made known? Which is, did they specify any form of artificial nutrition? And then if not, we have to then take a look at what the family decides, which can create some sticky situations. So you do have ethics boards at your facility. So if you're uncomfortable with a situation or if you're concerned about a patient's rights, etc., again, this is something that you need to bring up to your clinical nutrition manager, who can then bring it to the ethics board. Here you can see just an example of an enteral nutrition order sheet where, again, what's placed, so the specific procedure, the specific type of food. You can see this one has a formulary of 10 different formulas. Again, they have a specified start rate, how to reach goal, a spot for flushes, etc. All right, so questions. So if a patient has a functioning gastrointestinal tract but cannot maintain adequate oral intake, the type of route we should use is, and this is answer choice C, enteral nutrition. So if the gut works, still use it. To minimize the risk of aspiration during enteral feeds, patients should be positioned and so this is B, with the head and shoulders above the chest. So again, this is if you have a pillow underneath your back, right? You would be sitting up slightly, right? You don't have to be sitting up fully in a chair, but we do need to have the head and shoulders elevated. Question 3. So to prevent refeeding syndrome, patients who have not received nutrition support for a significant period of time should receive conservative amounts of, and so again, this is answer choice C, carbohydrate, where again, it's that transition from ketones back to using glucose and carbohydrate as our primary fuel source, that transition and that requirement of electrolytes and micronutrients is going to cause that shift and refeeding syndrome. So again, we need to keep an eye on and be conservative with the carbohydrate intake. And so that concludes the first part of chapter 14, focused on enteral nutrition. Now to prepare and be ready for the slides that will accompany the worksheet, please go to the App Store. So for your Apple or Android device, you're going to be looking for a product guide. So there is one for Nestle Health, or I believe they've called it Nestle Health Sciences, as well as Abbott. And you're looking for the product guide. So there are 2 apps, one from each company. You can also access the information from the internet, and you can look it up on their website. So depending on your phone, etc., if you are unable to access it, you will be able to access the information from their website. But again, I would just make sure that I have that window open when I'm working on the worksheet. So again, that's those 2 apps. That is Nestle Health Sciences and Abbott Nutrition.